Good evening, class. My name is Jita, and I'll be presenting on Week's 10 discussion on the geriatric patient. So, one of the first questions that I decided to expand on includes the pharmacological agents used for Midge, the patient. So, antipsychotics are commonly prescribed for older adults with neuropsychiatric symptoms. In the case study that we were presented, Midge did endorse wandering, both visual and auditory hallucinations, impaired judgment, inability to safely supervise her grandchildren, as well as some cognitive decline. As you guys have remembered, a lot of her symptomology can put her and others at significant risk for self and others. Midge was taking care and overseeing the well-being of multiple grandchildren, to the point where one of her grandchildren was found in an above ground pool. So obviously, the patient is at risk for a lot of self-harm and harm towards others. So it is important to explore these pharmacological agents that can aid in the delusions that she also experiences of that person that is on a woodpile. So the medication choice that I decided was risperidone or Risperdal, low dose, just 0.25 milligrams at bedtime. So the rationale and scholarly evidence does show that going low and slow with the Risperdal is due to the physiological differences in the metabolism of geriatric patients and subsequently the higher risk for side effects, notably EPS. So, with this treatment choice of Risperdal for Midge, the geriatric patient, I thought it was important to add some patient education with this. So, Midge's daughter can be aware of what to look out for, as well as Midge being able to report some of these symptoms if she does experience them. So, in terms of patient education, there is an FDA black box warning for antipsychotic use in geriatric populations that may increase risk for cardiovascular events such as stroke and MI. So again, it is really important to highlight this to Midge when it comes to treatment planning and educate Midge on the classic signs of stroke, unilateral paralysis, for example, inability to speak, as well as MI. So definitely very pertinent in patient education. Next, we have some non-pharmacological agents that may aid in alleviating Mitch's symptoms. So we have mindfulness that Mitch can be engaged with. A form of that would be stress management, especially in the context of Mitch experiencing a lot of auditory and visual hallucinations, as well as delusional thinking. So coming up with some effective stress management and coping skills to reduce the distress that she may feel when she does experience these neuropsychiatric symptoms. Next, we have personalized music therapy. So this may be helpful for Midge, who could essentially construct a music playlist where she can utilize it in times of wanting to de-escalate or feeling just very agitated. Could really just use music as essentially a grounding technique of some sort. And lastly, we have cognitive stimulation therapy. So, examples of that are completing puzzles, word searches, basically to really peak that cognitive aspect that is compromised in the patient's case. And it is important to note that although these options may not cure these neuropsychiatric symptoms of agitation and delusional thinking, they do essentially aid in symptom management and increase quality of life. And this is my reference page. I hope you guys enjoy the presentation, and I look forward to reviewing all of yours. Thank you and have a good night.